on to the next. Okay, so for the spleen, spleen is another secondary lymphoid organ, just like the lymph node. All right. So for the spleen, the most important information you want to remember about the spleen here is the location. All right, because you could talk about a question where the spleen is injured, right, or you have injured from a blunt force abdominal trauma. So you need to know the location where it is in the left upper part of the abdomen, right? And then the other thing about the spleen is the function, right? The function of the spleen. So when we talked of the lymph node, we said it drains the lymph. The lymph node is responsible for sifting the lymph, all right, to look for infectious or foreign antigens. The spleen is the blood. It sifts through the blood. It sieves the blood looking for infectious pathogens, right, or foreign pathogens within the blood. So if the spleen is not there for any reason, either from post-splenectomy, autosplenectomy, sickle cell disease, that will lead to increased susceptibility to what encapsulated organisms. Which are they? Strep pneumonia, Haemophilus influenza, pneumococci, all right? Pneumococci, I mean, meningococci, sorry. So we have pneumococci, Haemophilus influenza, and meningococci. So those are the three pathogens that are encapsulated bacteria, bacteria that are this post-splenectomy patients are susceptible to. So you need to vaccinate them against that pathogen. What are the findings in post-splenectomy? Howe-Jowe bodies. So what are Howe-Jowe bodies? They are remnants, cells that contain remnants of nuclear DNA. So this is what Howe-Jowe bodies look like. So you can see that purple spot there. There you can see there, that's the dark purple spots. It's a nuclear remnant. They're not supposed to be there in normal red cells. All right. So this one you can see this is normal, right? But this is not supposed to be there. So the spleen will typically remove that. But once you don't have the spleen, they will remain there. The other thing they said is target cells, right? So that thing they talked about is target cells. So when you have the target cells, this is the target cell, right? So this is the target cell. This is the target cell. This is the target cell, all right? Okay, very good. So that's something you need to remember there. You have the periarteriolar lymphoid sheath, so that's in the white pulp. So the follicles, so the white pulp has three main structures: the periarteriolar lymphoid sheath, the follicles, and the marginal zone. Okay, so the periarteriolar lymphoid sheath contains the T cells, the follicles, of course, B cells, just like in the lymph node, right? And they produce antibodies against the pathogens. And then you have the marginal zone. So the marginal zone is where the T cells, I mean, the splenic macrophages will come and are located. Once they come in from the red pulp, they will go to the marginal zone of the white pulp. And there in the white pulp presents the antigens to the T cells. Okay, that's what I said. The marginal zone contains the macrophages and the specialized B cells. Okay, so when we come to the cells of the immune system, we'll discuss what antigen presenting cells are. Okay, so they are essentially cells that will capture the antigen, blood-borne antigens, and present it to the lymphocytes for recognition. All right, so the marginal zone is what separates the white pulp from the red pulp. Right, so and that's where the macrophages from the red pulp will go to present antigens to the T cells that are in the periarteriolar lymphoid sheath. All right, so I think looking at all of that now, what happens when there is someone that has, for any reason, the spleen is dysfunctional? So some of the scenarios that will cause splenic dysfunction. One of them, he has had the surgery in the past. So you could have a case. A clinical scenario would be someone who has had a road traffic accident. The spleen is one abdominal organ that is prone to blunt force trauma to the abdomen, okay, leading to splenic rupture. Other disease conditions that can lead to splenic rupture are viral infections such as Epstein-Barr virus, infectious mononucleosis. Okay, that can also predispose to spleen rupture because it leads to splenomegaly, that infection. All right. So the other condition, sickle cell disease, particularly people from West Africa, okay, Nigeria specifically, right? Sickle cell disease, which will lead to autosplenectomy, right? So that will lead to decrease. So the antibodies that the spleen will produce, IgG or IgM, okay, that will be decreased. And we'll come to see that these antibodies are the only two that can fix complement. Complement is a set of proteins that are in the bloodstream that attack pathogens that get into the bloodstream, right? So those, so once those immunoglobulins are, they are there to fix. When they say fix the complement, they activate complement system, and that complement will go on to destroy the bacteria. Okay, so C3, decrease C3b. C3 is a component of the, is one of the components of the complement system. Okay, and it's the most important complement of the complement. I don't want to go into too much detail, but just know that they are numbered C1 all the way to C9. We'll describe them in detail. And C3 is the most important of all of them. So we'll look at that in future. We'll discuss that when we get to that point. Right. And that protein is required for a process called opsonization. Okay. So when you hear opsonization, it just means that the opsonins are more of like proteins that coat a pathogen and make it palatable for phagocytes to eat up that pathogen, right? So we'll describe that more in detail, but just know that when you hear opsonization, it just means it makes the pathogen more palatable, more easily digestible for the pathogen to be able to be easily chewed up, to be swallowed by a phagocyte, right? So that's what opsonization means. So that means when you don't, when the spleen is gone, like I said, the spleen is the major organ where antibodies are produced. So when the spleen is gone, antibody production drops, all right, IgG, IgM drops. There's reduced complement activation, C3 complement activation is reduced, opsonization also does not happen. And then those bacterial pathogens, particularly encapsulated pathogens, run around free and they are not destroyed by the spleen, splenic macrophages also. So that person comes down with overwhelming sepsis. Now, why am I mentioning all of this? It's important because there are you could get questions that will test you on different aspects of this. All right. Ask you what will happen if someone doesn't have a spleen. Okay. What are the things they can what are the kind of organisms they can come down with? What is that process that happens? The pathologic process that can happen due to a splenia or post-splenectomy patients, in post-splenectomy patients. So it's very important for you to understand the pathogens that the spleen, number one, is this is the most important function that I'm talking about here, clearing blood-borne pathogen, systemic clearance of blood-borne pathogens. That's the most important function of the spleen, right? The most important function to clear blood-borne pathogens. All right. And how does it do it? It produces immunoglobulins, like IgG, IgM, that are attached to the bacteria and activate complements. And those complement proteins will allow the bacteria to be absorbed or to be digested by phagocytes. That's white blood cells that eat up foreign pathogens, okay? Particularly encapsulated bacteria or organisms. All right, so what are the things, now we'll move on to the next part of the, what are the things that you will see in patients that have had their spleen removed? That's post-splenectomy findings. All right, so the first thing we see here is Howell-Jowell bodies. All right, so let me show you an image of, so this is Howell-Jowell bodies, right? So this is a nuclear remnant, okay? So that's retained DNA, nuclear remnants, okay? So that's what it is. So all these tiny dots, basophilic structures, Uh, that's a Hojaro body. So normally, what happens, well, as red blood cells mature, as they are being produced in the bone marrow, they typically have remnants of nuclear DNA that remain in those red blood cells. But most red blood cells are able to remove it, are able to remove this remnants in them. But then some red blood cells are not able to extrude that or get rid of the DNA remnants. Okay, so the macrophages in the spleen will identify those cells and remove them, destroy those cells. All right. So in patients that don't have had their spleen removed, these Owejawa bodies will remain. So you'll start seeing white blood cells in the peripheral smear that have retained nuclear DNA. Right. So, but if the spleen was present, it would have removed all of that. It will remove red blood cells that have this nuclear DNA remnant. So in a person that has a normal functioning spleen, you won't see Owejawa body in the peripheral smear. All right. So what's the other thing you will see? Target cells. Okay, so target cells are like cells with a bullseye. Okay, so these are target cells, all right? So the target cells, the arrow is pointing at. So they have a bullseye. I like to call them donut cells, but not exactly a donut. So they have that pink central staining in the middle of the cell. Okay, the normal cells have a central pallor, but then target cells will have another staining within that central pallor, so making them a target cell. So what that the target cell just shows is excessive nuclear membrane. Okay, excess red cell membrane that is retained. So as the cell, like I mentioned, I talked about in the red, all of this point to the second function that I mentioned of the spleen, to remove abnormal or old red blood cells. So as cells, red blood cells pass through the sinusoids of the red pulp. Okay, they have to meander their way through those sinusoids because they are tiny spaces, and the red cell has to deform itself. And as it's deforming to pass through those sinusoids, it's losing any excess membrane that it doesn't need. All right, it doesn't need. So to maintain that biconcave shape that gives it that central pallor. Okay, but when you don't have the spleen anymore, okay, that excess membrane that's supposed to be removed as this red blood cell passes through these sinusoids in the red pulp, they don't have to go through all of that. So they retain that excess membrane, and then that when you do a peripheral smear in patients that don't have a spleen, it appears as a target cell. So that target cell you're seeing, that central staining, is just a matter of excess red cell membrane that is retained in the red cells. Okay. And for the next thing, we have the thrombocytosis, right? So thrombocytosis, I would say, it stores. This points to the third function of the spleen, which is it stores blood, right? So about 30% of platelets or so, the lymphocytes, are stored in the spleen. So the spleen stores the blood. So in case of shock, also it can release that stored amount. All right. So once you don't have, the spleen is gone. There's lots of sequestration. That's one. And number two is that not just the red blood cell, but also even old lymphocytes are removed by the spleen. All right. So once the spleen is gone, that you have both new and old platelets. They are not removed from the bloodstream. So that's why the patient comes out with the post-splenectomy patients who have thrombocytosis as well as lymphocytosis. Okay, because in addition to not storing the excess blood, the old platelets and lymphocytes are not removed. So that leads to elevated platelet and lymphocyte count. All right. So what's the most significant thing here about people that have undergone splenectomy? That they have to be vaccinated. Okay, they have to be vaccinated against encapsulated organisms, right? So that's pneumococci, Haemophilus influenza, Neisseria meningitis. Okay, those are the three that they have to. And in some cases, they also have to take prophylactic antibiotics, right? So they require vaccination against encapsulated organisms, right? So another thing I forgot to mention about these target cells is that there are several conditions that give rise to target cells. You come across that in your hematology. Well, I ask you. So there's a mnemonic for target cells, conditions that lead to target cells. Okay, so that mnemonic is HALT. Okay, so this is thalassemia, liver disease, asplenia, and then hemoglobin C, hemoglobin C disease. Okay, those are conditions that you see target cells. So, well, not relevant here, but when you get to hematology and you hear see target cells, all right, you know that HALT is part of what accounts. Those conditions can give you target cell, all right? Okay, so let's move on to the thymus. So the thymus, as I said, is a primary lymphoid organ where T cells for T cell differentiation and maturation, right? And it's located in the anterior superior mediastinum. Okay, so this is uh, yeah, so this is where it's located. So this will be your anterior mediastinum there. Okay, the part in green. So that's your anterior mediastinum, just sitting on top of the heart. So once you remove the sternum, okay, for those if you've done autopsies, if you do an autopsy in a child or so, you see it sitting just on top of the heart there, right? So that's where it is, anterior, just in the anterior mediastinum. All right, and it typically involutes after the age of 3, okay, around the age of 3, but doesn't mean I've seen it in older people who done autopsies in older individuals, and I've seen them. So it doesn't mean that it goes away completely, okay. And sometimes that's why, in some cases, those people some patients can the thymus can then grow to be, instead of evoluting, it can then become a tumor, which we refer to as thymoma. But I'm coming to that. I'll get to that shortly. All right. So like I said, the thymus is the site of T cell differentiation and maturation, right? So if anything disrupts the ability or the process of the T cells going to the thymus to undergo their maturation, that will lead to T cell either you have absence of T cell, no T cell, or T cell dysfunction. All right, and we said that will lead to viral, fungal infections and failure to thrive and all kinds of symptoms that we'll look at shortly. All right. So the thymus is encapsulated. All right. It also has two parts to it. Or before I get to that, so it develops. Mentioned earlier, it develops from the third pharyngeal pouch. Okay. So the thymus is from third pouch, parathyroid fourth. Okay. So the thymus develops from the third pharyngeal pouch, parathyroid gland develops from the fourth pharyngeal pouch, right? And then the thymus endodem the thymus endodem from the third pharyngeal pouch, whereas the lymphocytes that come to the thymus to develop are from mesodermal origin because the bone marrow, they are coming from the bone marrow. The bone marrow is of mesenchymal origin, so that's why it's from the mesodermal origin, right? So the T cells that go there are from a different origin as the thymus itself. Okay, the thymus is endodermal in origin, but the T cells that go there are mesodermal in origin. All right. Okay, so so it has two main parts. So let's look at that. So the thymus has two main parts. It has the cortex. Okay. So it has the cortex and the medulla. Right. So let me show you. an image of that. So yeah, this is the thymus in the fetus, all right? So you can see that's the cortex there, all right? So that's the, so this is the cortex, all right? So this is the cortex right up here. All of this is the darker area, okay? So all of this is the cortex, all right? Then the pale central area here, okay? This is your medulla, okay? Just this, all right? So this is your medulla right here, okay? So, and the cortex is dense, like we said, is darker staining and contains the immature T cells, all right? So the cortex contains the immature T cells, while the medulla is pale, like we've seen, and contains the mature T cells and the basal corpuscles, okay? So what does that say? This place is where the immature T cells are located, all right? And then your medulla is where the mature T cells. So what happens is that the when the T cells come to mature in the thymus, they first get to the cortex, all right? They come in through the cortex and then proceed down to the medulla, all right? So the medulla is where you find the mature T cells. There's a page on this in first aid that describes this in more detail, but just know that in the cortex of the thymus, you have the, which is darker staining, you have the immature T cells, and then the medulla, which is light in color, is where you find your your okay, this is, so that's where you find the 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 mature T cells. Okay, so let's move on. So the T cells and the Hassel corpuscles are found in the medulla, and they contain, that's the mature T cell. The Hassel corpuscles are found in the medulla, and they contain the reticular cells. So the normal thymus is cell shaped, all right. And you can see that on chest X-rays. And this is important because you get a question where they'll say, okay, you have a child younger than 3, where you can't find the the thymic shadow is absent. All right. So if you hear that absent thymic shadow, okay, absent thymic shadow, then that tells you that something is wrong with the thymus. And if something is wrong with the thymus, then something is wrong with T cells. All right. And if something is wrong with T cell, then something is wrong with the immune system, and that patient will be prone to certain kinds of infection, particularly viral, okay, fungal, and other symptoms as such. So just this thymic shadow, very important. Some questions can give you the chest X-ray. They will describe the patient. They won't tell you absent. They will just give you the X-ray, and then you have to look at it and see if there's a shadow or no shadow. All right, and then based on the symptoms of the child to see if you're thinking of if there's thymic hypoplasia or aplasia. Okay, all right. So to reiterate, we said the T cells go to the thymus to develop. So the T cells are not produced in the thymus; they just go to the thymus to mature. All right. The B cells mature in the bone marrow, but both B and T cells are produced in the bone marrow. All right. So, like I mentioned before, absent thymic shadow or hypoplastic thymus is seen in several immunodeficiencies, such as this is severe combined immunodeficiency, right, and DiGeorge syndrome. They have basically the same. They appear as in terms of the effect on immunity is the same. So both of them involve the T cell development, right? And then both of them you will see absent thymic shadow. But then the judge is different because it involves both the third and fourth pharyngeal part. So the parathyroid gland will be affected in the time in the judge syndrome, but not SCID. All right. The pituitary gland is affected in the George, but not the SCID. Okay, so moving on, let's talk about the tumors. So this thymoma is a tumor of the thymus, and like I said, even though it involutes in childhood, can still find it in our thymus, can still remain all the way to adulthood, and can even grow and enlarge to become a tumor called a thymoma. Okay, that's a tumor of the thymus. All right, and as associated with several syndromes, these syndromes are extremely important. Okay, very, very important for you to know them. Let's so myasthenia gravis. All right, so you could get a history where you see patient a mass in the anterior mediastinum. It will give you a CT scan. Okay, let me see if I have something of that nature to show you. Where okay, yeah. So you can see this, right? So this is the front. Okay, let's. So this is the front of the chest. This is the front. This is the back. As you can see, the vertebrae is here. All right. This is part of the esophagus. All right. This is part of the great vessels here. Okay. Then your heart is around there. Then there's a mass here. Okay. So this is in the anterior mediastinum. This is the middle, and this is the posterior. So this is the middle, posterior, anterior mediastinum. Okay. So you're going from the front at the top here to the back at the bottom, right? And you can see that mass very large there. Okay, so they will give you that CT scan and tell you, okay, the patient has fatigable weakness. The patient gets weaker as the day progresses. He has diplopia and all those other symptoms. Okay, and then several or maybe they can want to confuse you and say there are other autoimmune diseases as well. Okay, maybe I don't know, probably type 1 diabetes as well. Okay, and then they'll give you the CT scan image, and then when you hear fatigable weakness that gets worse as the day progresses, and then it gets better when he takes a rest. Then and with this CT scan image, you start taking out myasthenia gravis. Okay, the other thing is they will have several drugs that you say, okay, patient went to surgery and they gave him some drugs, and then he went into crisis, myasthenic crisis. Okay, so you need to know several kinds of drugs that can tip the patient that has myasthenia gravis into a crisis. Okay, and that's one way you suspect they have myasthenia gravis. Okay, but for the purpose of a thymoma, you see an anterior chest um, mass in the anterior mediastinum with history of muscle weakness that gets worse as the day progresses. So he gets up in the morning, he's better, no problem. But as he goes to work, he's doing his work. Towards the end of the day, he gets progressively weaker and sleeps, and then wakes up the next day, feel better. Okay, that's how myasthenia. And then what happens in myasthenia gravis? There are antibodies, auto antibodies. Okay, auto antibodies against the ACH receptors in the motor end plate. Okay, ACH receptors in the motor end plate. All right. So it's usually associated with that and mass in the anterior mediastinum with autoantibodies against us. So those antibodies block the acetylcholine receptors and prevent acetylcholine from binding to its receptor, and then and so because acetylcholine can bind to the receptors on the muscle end plate, can stimulate muscle contraction, and that's what leads to the muscle weakness. All right, that's what leads to the muscle weakness. Then the other thing, superior vena cava syndrome. So like we said, this mass is it's in the it's in the anterior chest wall there, and as you can see, it's very close to these blood vessels over here that you can see. So in superior vena cava syndrome, okay, what happens is the thymoma, and it's not just a thymoma that can happen. You can see it in pancreas tumors as well. Okay, tumor in the superior circles of the lungs. All right. So what does that tumor do? It compresses the superior vena cava. All right. So if let me see if I have. Let me just go back. So if you have your brachiocephalic veins, okay, that join to form your superior vena cava here, you have your brachiocephalic veins, okay, and then you have the mass here. Then you have the mass here that's compressing on it. So what does that do? It blocks it to prevent drainage down to from the brachiocephalic veins into the superior vena cava and then into the heart. So there'll be backlog of blood. Okay, so you could hear a history of if someone with they give you a scan of someone with a mass in the anterior mediastinum, and then you see they'll describe it as a plethora or engorgement of the veins of the head and neck, and particularly the right side, the right upper limb. Okay, because since you guys are going to the US, you're dealing with they'll give white Caucasian patients. So, of course, if there's that blockage of blood draining from the head and neck and the right upper limb, there'll be engorgement that of those parts of the body. So they will appear redder, much more red compared to the other parts of the body. So, and that happens, you can see that in the thymoma as well as, okay, pancreas tumors. Okay, that's a tumor in the superior, that happens in the superior poles of the lungs. Okay, and that's a lung cancer that's involving the superior pole of the lungs. So it extends it up right into the neck region and it's blocking drainage from the head and neck. Okay, so that's what causes. So superior vena cava syndrome is anything that blocks drainage from the head and neck into the superior vena cava. That's what superior vena cava syndrome is all about. Okay, so for pure red cell aplasia, okay, what happens there? You find a patient also with a thymoma, okay, plus anemia. That's also it. So it doesn't affect platelets. Platelets are not involved. The white blood cells are not involved. So it's just thymoma with anemia. Okay, that's why I say pure red cell aplasia. And so for some reason, the and the immune system begins attacking the red blood cells, and then which leads to anemia. Okay, the pathogenesis is not clearly understood, but it's not associated with a thymoma. Okay, and then Good syndrome is also, so each of these things you have a thymoma, and then you have thymoma plus hypogamma globulinemia, so low immunoglobulins, right? So also autoimmune. Okay, so the body starts attacking the B cells. The T cells are abnormal, and they start attacking the patient's B cells. And then we said the B cells are responsible for producing immunoglobulins. And so once B cells drop, okay, immunoglobulin levels to drop. Okay, B cell numbers will drop, and because they drop, T cell immunoglobulins too will drop. Okay, so that's what causes good syndrome. So this is different from good pasture syndrome. So it's not the same thing. Good pasture is immunoglobulin complexes. Okay, not just so immunoglobulin that involves the lungs and the kidney. So it's different from good syndrome. Good syndrome is a thymoma plus hypogamma globulinemia. Okay, it's different from good pasture syndrome. Okay, so is there anything I am missing? Okay, so any questions?